Dear colleagues, I would like to welcome you all to this session regarding autoinflation for treatment of otitismedia with effusion. I would like to thank the organizing committee for this opportunity to be here and talk about my research. I would like to start with a declaration of conflict of interest. And I must admit that there is nothing as lucrative as grommet surgery on children in my private practice. My second conflict of interest is that I'm the inventor of the autoinflation devices that I'm going to present to you today. Otitismedia with effusion continues as one of the most important challenges in modern medicine. Based on the Swedish population of about 10 million inhabitants, we got 60 million euros yearly put on otitis treatment. Well, for most doctors, this is just a 6 with a lot of zeros. If we correlate this number to the total amount of money spent on healthcare that specific year, this represented almost 0.5% of the total, which is a little bit alarming because you would expect Sweden to be one of the best countries for treatment of otitis. However, the figures there show that we got 400,000 cases with OME per year, of which we treat about 10,000 per year, so it's 2.5%. So more than 90% of cases with otitismedia with effusion in any country in the world go around without any active treatment. This is, of course, related to the treatment options that we have available. We have had either grommet surgery compared to basically doing nothing that we very beautifully call watchful waiting. The grommet surgery itself has also been criticized. So it has been a dilemma for us ENT doctors, whether we have operated or whether we have tried to wait it out. We have had like critics. If we don't do anything, then we got a problem with the child suffering from a possible hearing loss in an important age. And we have performed the surgery. We have had other kind of critics, especially when the complications come up of this surgery. Another issue that has been very important is the eustachian tube dysfunction, which has been discussed from decade to decade. And right now, what I noticed at the World Congress is that we are in a surgical wave of treatment of eustachian tube, especially in adults, but some studies are actually starting to focus on children to treat the basis of what we call the mother of all evil in middle ear diseases. Talking about the non-surgical management of eustachian tube dysfunction, well, the history of that goes back to Antonio Maria Valsalva, with his description of the eustachian tube and his famous maneuver to open the eustachian tube, which is very efficient in adults, but which has almost been impossible to perform in young children. Based on this difficulty in performing a maneuver, several devices were developed. One of the most famous ones was the Pulitzer pump that was popular for about a century ago, but it was abandoned because of the discomfort to perform this treatment on young children. Then Hunt Williams introduced the so-called nasal balloon that still is one of the most important devices for autoinflation. So Hunt Williams, from his publication in 1968, he basically described the nasal balloon, the nasal piece, how to perform autoinflation, and his results regarding that. And where do we stand today when it comes to autoinflation? We still continue with the nasal balloon as the most acknowledged treatment. And we have also introduced a modern type of Pulitzer pump. They are basically mechanized, but they perform the same thing. There are nose-based. You have to hold for one of the nostrils. The mouth has to be closed, and then you put the pump there, or you encourage the child to try to inflate the balloon. According to the Cochrane Library, the autoinflation should be the treatment of choice during the so-called watchful waiting period that could be from 3 to 6 months. And in some cases, you could actually consider to extend it to 12 months if the child has got unilateral UME and no other affection of quality of life or speech. However, important critics have been raised from the ENT society. How about compliance? I mean, it's not possible to perform any of these treatments below the age of 4. And it's extremely difficult below the age of 5. How about effective hearing? I mean, the nasal balloon has a half a century of medical studies, and we cannot find one single study showing black and white that the hearing of the children are improved by these methods. How about long-term studies? We don't have any studies following these children past 6 or 12 months to see what happens with them after autoinflation. And how about comparative studies? The gold standard today for treatment of children with OME, with hearing loss, is grommet surgery or ventilation tubes. So how about comparing these autoinflation devices to ventilation tube surgeries? This was basically the knowledge when I started my PhD thesis in 2009 at Gothenburg University in Sweden. So we tried to develop a new device that would surpass the difficulties encountered with the previous devices. One of the most important issues was that everything that has been described as autoinflation in the medical history until that date was based on nasal maneuvers or nasal devices. So how about trying to perform autoinflation by mouth? I mean, most of the children below the age of 5 have adenoid hypertrophy or some kind of nasal symptoms. And it's not easy for them to even blow their nose. So it's, of course, extremely complicated to perform these maneuvers by nose. We managed to surpass this difficulty just by an anesthetic mask that covers the nose and mouth of the child. Furthermore, the previous devices required that the child has the mouth closed or open up the mouth to breathe in, hold for one nostril, and then blow out by the nose. So extremely complicated coordination, even for some adults. Elderly adults have difficulties using these devices as well. So a child of 2 years, 3 years does not understand these instructions. So we just solved that by unilateral valve. So you just cover the nose and the mouth of the child, and the child can breathe in. And as fast as the child breathes out, the air goes to the balloon. And hence you got a counter pressure. You create a high pressure in the upper airways that sooner or later will reach the eustachian tubes and open up the eustachian tubes. Furthermore, how do we do with the children that have not got the lung capacity to inflate the balloon to the desired size or the balloon of a certain counter pressure? Well, we solve it with the pump. The pump system aids the child to increase the pressure and inflate the balloon. Of course, there is a security valve of 40 centimeters of water in the neck of the frog, and this will open to avoid uncomfortably high pressures within the system. Furthermore, the total pressure in the system is defined by the balloon. So you have a compliant system, you got a high security valve, and the most important thing of all, you can have the best pill in the world. If the patient doesn't take it, it has no effect whatsoever. So the frog creates a new friend, a new body, a pal that they can sleep with, they can play with. And the frog inflates on one side, blows on one side, the child does it on the other side, and together they manage to treat their otitis. From theory to practice, you got a device that is extremely popular, and it's a very child-friendly looking medical device. Comes with balloons of 2 different pressures. And the most important instruction here is to seal the mask tight. Basically, it's just to breathe in and breathe out. The child can breathe with open mouth, the child can laugh, the child can cough inside that. And when necessary, the parents can help by squeezing the pump that is within the belly of the frog to give an aid to the child to inflate the balloon. And most children prefer to do autoinflation by mouth. And you can, of course, do it through the nose. It's efficient, even though you scream in it. And as we explain it to the patients and parents, doing so, you hear the crackling sound and the liquid will be drained or ventilated. Comes with a calendar to create a more educative moment. They put a blue sticker for the blue balloon days, and they put a red sticker for the red balloon days. From a practical point of view, what we recommend is that they perform 4 weeks of autoinflation by the blue balloon, and then they have a control. and to see a little bit if the glueear has disappeared and the hearing is restored. If that is not the case, they repeat the treatment by another 4 weeks with a high autoinflation pressure with a red balloon and have another control. We have had a lot of studies. It was included, as I mentioned, in my PhD studies. So the first things that we focused on, what is the pressure requirement here to open the eustachian tube? And we started by healthy individuals. So we tried 40 centimeter of water, 60, and then we went up to 80 and also 100 centimeter of water in the balloon pressure. We noticed that the pressure from 40 to 60, there is an advantage there in some patients, but increasing the furthermore, there is no effect whatsoever. So either they respond to the 60 centimeter of water pressure. If they don't do that, then you have to change the maneuver. And as I was describing, we tested different maneuvers. How about inflating by nose? How about doing it through the mouth? How about coughing? How about laughing? How about screaming or even crying, which happens in flight when the child is suffering from a severe ear pain? You just have to cover and hold the mask tight. Any respiratory movement, jaw movement may aid to open the eustachian tube and ventilate the liquid. Another maneuver that can be considered is, of course, the activation of the pump to increase the pressure within the system. And this increases also the efficacy of the system. Then we did short-term autoinflation tests, several minutes in adults, in children, with extremely high compliance, almost 90%, and almost 100% ventilation rate in the healthy individuals, children and adults. And based on this device, we got these fabulous footages. For the first time in the history of medicine, we can see children, independent of age, perform autoinflation, either autonomously or by the help of their parents. Never before have we seen a child of 1 year of age, or even below the age of 1 year, like this baby of 8 months, to perform autoinflation, actually collaborating and being proud with a smile in her eyes that she has been able to blow up a balloon for the first time in her life. Result-wise, we included in the first studies that were in my PhD thesis patients that had chronic disease with bilateral OMI with confirmed hearing loss in the waiting list for surgery. We included children from 2 to 8 years of age, and we noticed 100% compliance after instructions, whereby after 4 weeks of treatment with adequate maneuver and adequate balloon pressure, 8 of 10 children avoided surgery based on hearing improvement. We followed the children during 12 months and noticed persistent audiometric and tympanometric results. They might in some occasions have recurrence of disease, especially during the cold seasons, but since they had the device at home, they could repeat the treatment for another 4-week period. Our latest studies include children with craniofacial alterations, such as, for instance, Down syndrome. We have tried this device out on children with otitis. We have, of course, only pilot studies here, but our results are extremely interesting. We have been managing to avoid surgery in most cases of these children, maintaining a high quality of life, normal hearing during most days of the year in these patients. We have, of course, separate quality life studies on children with OMI, and we noticed that their quality of life is significantly improved after autoinflation therapy by this device. It was also interesting to compare this device to the established international treatment, the nasal balloon. And we performed this in nurseries in so-called normal children. And we noticed that the compliance-wise, there is a large difference. You go from 90 almost to 10% of compliance, and that goes also for efficacy of treatment. So they are not comparable. And the lower the age level, the more the difference. So if you can imagine a 2-year-old, 3-year-old child, or a 4-year-old child with a nasal balloon. It's almost impossible to make them to use that and gain interest to use it daily. Meanwhile, the froggy speaks for itself. It's a pal, it's a friend that follows up the child during the growth until the disease disappears by itself, hopefully after 5 or 6 years of age. This is a video showing the compliance of children with Down syndrome. These are twins that I've been following up for several years. They are very, very interesting. I mean, they have a competition in between them, which is very, very common in siblings. And they always compete of who inflates more balloons and who is the best one to play with a froggy. And now getting to the study, comparing autoinflation to ventilation tubes in children with chronic otitis media with effusion. We included 142 patients in the waiting list for surgery. All had secretoryotitismedia confirmed by tympanometry and hearing loss confirmed by audiometry. So we got 45 patients in the ventilation tube, 45 patients in the autoinflation group, and we only managed to recruit 23 patients in the control group. The parents were a little bit afraid that they might lose more time just waiting and doing nothing. So of course, just to get to the point that we're inserted to the ventilation tube surgery, waiting list for surgery took such a long time that they didn't want to lose much more time there. So we managed to get a small number of patients, and we managed to only follow them up during 1 month. However, the patients in the ventilation tube and the autoinflation groups were followed up during 12 months with audiometry at 1, 6, and 12 months. And our main goal here, of course, was to compare this treatment to ventilation tube, and we had a randomized control study, so we are confident about our results on children comparing these two treatment methods. There was no significant difference in the mean hearing threshold in the best ear, the gender, the tympanometry type, season of inclusion, or previous surgery in these children. And what we noticed was that most of the children had B-type tympanogram, about 80% in all the groups, and the other, and that was their worst ear. In the best ear, all had C2 tympanometry. So if the child had a C1 or A tympanometry, we would exclude them from this study because we won't have the worst case scenarios to see how they would handle these treatments. So regarding our most important finding, the hearing thresholds in children. To start with, the compliance level in the autoinflation group was 100%. So after instructions, we managed to teach the children and the parent how to use the devices. It was extremely simple. And we helped the parents to choose out the right maneuver for their child, and choose the right balloon pressure. For instance, we had 2 balloon pressures, so it wasn't so difficult. We tried the first one and they were good to go into the second one. And regarding the maneuver type as well, as I was explaining previously, the most efficient maneuvers are by mouth. For instance, coughing is extremely efficient, and activating the pump is extremely efficient as well. And if we take a closer look at this diagram here, you can see in the green, you see the autoinflation group. In blue, we have the grommets group or ventilation tube. And in black, we have the control group. So this is time 0 at inclusion. And you can see that past 4 weeks, the control group didn't improve its hearing, got a hearing level here that is basically stable. Meanwhile, the both treatments group had a significant improvement in their hearing level in the best ear. And that change basically maintained itself past 6 months and also at 12 months. However, you started to notice a discrepancy between the autoinflation group in green and the ventilation tube group in blue, which is explained by the fact that some ventilation tubes are exposed and the child gets a new cold, and of course you don't jump onto a new surgical treatment. Meanwhile, since the child had their autoinflation device at home, they could very simply, after a new cold period, when the upper airway symptoms were gone, they could restart the treatment and do another 4-week session of treatment, maintaining the middle ear healthy by that. Complication-wise, well, as expected, the autoinflation group didn't represent any complications. A transient discomfort in the ear could occur in some children, but that didn't make them to stop the treatment. By motivation, the parents could continue and carry on with the treatment. And recurrence-wise, you had a difference between the ventilation tube group and the autoinflation group, which might be explained that the ventilation tube surgery in many cases was combined by the adenoid surgery or the tonsil surgery that might have reduced the tendency of upper airway infections, at least during the 12 months follow-up period that we had. Complication-wise, no complications as mentioned in the autoinflation group. Meanwhile, we noticed 34% complications in the ventilation tube groups. So the most common things were pain, otorrhea, tube obstruction, early tube extrusion, and persistent perforation that we noticed in one case. So take-home messages. Autoinflation has already been acknowledged as the only non-surgical treatment of OME with possible effect on hearing. So what we have done basically during the last decade is that we introduced a new generation of devices that are easy to use for a home treatment of OME. They are extremely child-friendly to the degree that children consider these devices as toys and not medical treatments. No complications have been reported so far. And we have been able to show that there is an equivalent improvement in hearing on these children treated by autoinflation compared to ventilation tube surgery. So from an ENT perspective, from an adult perspective, we might accept that it is fair to assume that if a certain condition is uncomfortable for an adult, then it should be uncomfortable for a child as well. Talking about OME, our guidelines today say that if you got a hearing loss on one ear, equivalent to putting a finger inside the ear, and I challenge you all to do so during the next lecture to see how it feels for a child to go around with unilateral OME. It's extremely annoying to hear your own voice echoing in your head, to communicate with other individuals in an important stage of your life when you want to develop your social skills and speech development, and many social capacities might be affected by that. And then you've got children going around with bilateral hearing loss. And we recommend them to wait for 3 months without any treatment whatsoever. In some countries, 6 months. If they got unilateral disease, we might extend that to 12 months. I mean, as an adult, if I, as an adult, cannot handle this, not even one day, one Congress day, how can we then recommend that to our children, to our so-called defenseless children, because they do not have the capacity to tell what's wrong with them. And then we might have so-called weird behavior syndrome at the kindergartens. There is no need for watchful waiting. You discover the patient. Imagine that that patient is your own child at home, suffering from unilateral hearing loss. Wouldn't it be nice for him to recover his hearing immediately by the first autoinflation already, then carry on the treatment for the chronic diseases to get rid of this, and have the treatment at home when he gets a new upper air infection, just to be able to treat the disease directly? I think the most important message is this: we don't have to do that anymore. We have a new solution. With this, I thank you all for your attention, and I am open to any questions that you might have.